In episode 1, we saw pattern persistence, the moment the injury story breaks. In episode 2, we saw progression, what delay changes at every level. In this final episode, episode 3, we focus on alignment between the clinician's suspicion and the radiologist's read, between the imaging finding and the referral pathway, between the question asked and the answer received. Because a scan does not diagnose a patient, but the right scan, ordered with the right question, can end a 2-year detour. Dr. Botany is a musculoskeletal radiologist at UC Davis who works closely with orthopedic oncology through weekly multidisciplinary conferences. His practice sits at the intersection of imaging detail and clinical context, where what the referring clinician writes on the order can change what the radiologist looks for. Dr. Botany, thank you for being here today. We greatly appreciate your insights. It's an honor. Thank you. When the clinical question is framed as a sports injury, what makes TGCT easy to overlook on imaging?
While we as radiologists commonly are able to figure out the history based on the imaging, meaning that, oh, I see the ACL appears to be torn. Okay, well, how did that I have this, or I see that there's findings that suggest patellar dislocation. I can speculate on what they were doing. We are dependent upon history when things are questionable. Like the diagnosis could be this or that. And so the first is we are biased by the history that's provided to us. So when the history provided is one of something like acute injury, we often don't immediately think of that. More often, the situation that we encounter on imaging is, frankly, it's an incidental finding, meaning the person who comes in and the indication is like a knee MRI ordered by their primary care physician for chronic knee pain. And you look at it and maybe there are some findings of arthritis on the MRI. And a tenosynovial giant cell tumor has some MRI characteristics that overlap with other diagnoses, which can include things like what we call an intra-articular body. An intra-articular body, or some people term that synovial osteochondromatosis, can look similar to a tenosynovial giant cell tumor. They both most MRI has what we call T1 and T2 sequences. T1 accentuates fat, T2 accentuates fluid. And usually a tenosynovial giant cell tumor is fairly dark on both of those sequences. An intra-articular body, which can be found in somebody who has arthritis and they break off a piece of cartilage, maybe break off a piece of bone, can look very similar. So you can think, oh, it's just an intra-articular body. What gets tricky is, what if there are no findings of arthritis, but it looks like an intra-articular body? Because what I first think is, oh, it's an intra-articular body. So where is the donor site? Meaning, where did the piece of cartilage and bone come from? Like, oh, it came off of again, we'll use the knee, it came off the patella, or it came off their distal femur at the lateral femoral condyle. So that's the one diagnosis with a history of, oh, it's either an acute injury, and then we see a body, but I don't see a donor site. There are other diagnoses that can also overlap with that, which is that tenosynovial giant cell tumor has two broad categories, one that's termed nodular and one that's termed diffuse. And the nodular type looks more like like I said, a typical intra-articular body. The diffuse type is something that people will describe looks more like frond-like and coats the entirety of the joint capsule. That can mimic hemorrhage like you see from somebody who has other reasons for hemorrhage, be it they're on anticoagulation, or they had recent trauma and they have hemorrhage, Or a bigger one to think of is somebody who has hemophilia and they have repeated hemorrhages. That's the one that can be even more so confused. So while I said I, as a radiologist, can often decipher history based on the imaging, the history you provide still will lend me toward one area and not necessarily consider that diagnosis.
Radiologists are biased by the history provided. When the indication says acute injury, TGCT is not on the differential. More commonly, TGCT presents as an incidental finding on MRI ordered for chronic pain. The nodular type can mimic intra-articular loose bodies, like a piece of cartilage that broke off. The diffuse type can look like severe synovitis, a hemorrhage, or even hemophilia. The key distinction, and the question that should be asked, is there an identifiable donor site for that loose body? Is there arthritis to explain it? If not, the diagnosis should be questioned. What should sports medicine physicians actually write on their MRI request to help you and other radiologists consider TGCT?
Well, you actually gave the answer, which is consider tenosynovial or question tenosynovial giant cell tumor. Now, more broadly, besides, if we just say the last word in that,
Right.
tenosynovial giant cell tumor. So question of tumor would actually just be, that would make us think, oh, should I be giving IV contrast? Because for musculoskeletal imaging, while I said most of the time we don't give IV contrast, the two categories, broad categories where we commonly do, are tumor or infection. So if somebody has any even inkling of tumor, now if you don't want to use the tumor term because that has some negative connotations, question of mass. When you say mass, I still think essentially tumor, but it may be a benign tumor. So I think when we think tumor, sometimes we think malignant tumor.
Right.
But it doesn't have to be a malignant tumor per se.
Even writing question of mass changes the read entirely. The word tumor carries negative connotations, but mass is clinically neutral and still puts TGCT on the radar. The simplest intervention: include the suspicion in the order notes. For suspected TGCT, what is your preferred imaging modality protocol, including MRI sequences and the role or not of contrast?
Most musculoskeletal imaging has a very basic algorithm in terms of imaging, which is that somebody has symptoms. Most often we start with a radiograph. And then if the symptoms are not explained by a radiograph, this is again just broad, most often then we proceed with an MRI, but usually without contrast being that we don't inject anything into the joint, we don't inject anything via IV into the person. And that is good for 99% of the time. For the diagnosis of a tenosynovial giant cell tumor, the administration of IV contrast is really helpful in that classically it will avidly enhance, meaning that we give contrast and then on the images it appears very bright. Conversely, like an intra-articular body from just arthritis will not show that enhancement pattern. So actually the administration of contrast can really distinguish between the two. However, again, for 99% of the people who present with some symptom of knee pain, that contrast was not needed. So that's why we usually do not, for most patients, administer IV contrast. This is the tricky thing. The whole point of, I think, this is that it can be misdiagnosed because you're not thinking of it, and most patients are not getting IV contrast. And so usually, again, I would like to start with a radiograph. The radiograph just to show, is there an intra-articular body that's ossified? Is there evidence of arthritis? Classically, the diffuse type, which I said, I think people less often mistake that one, but the diffuse type can have bony erosions on the radiograph. And it can have periarticular osteopenia, meaning there's bone turnover and it looks lower in density there. On the nodular type, which is just, again, a focal mass, you may not see anything on the radiograph. And so that person usually go on to an MRI. I said usually that MRI is not going to have any contrast. Now, if you suspect that as a diagnosis, though, which is your question, it is preferable that that person gets IV contrast. Is it absolutely necessary? No, it's not absolutely necessary. If you're very astute, you can pick it up, and we'll see examples of that. But ideally, you give IV contrast. Now, here's the other thing. Some textbooks, some medical journals, and will describe that you should do this one sequence that's called a GRE sequence, gradient echo sequence, and that is more sensitive in the diagnosis. That is like a test question answer. It's more nuanced than that, though, in that people have researched that. And there was a publication a few years ago in the Journal of Skeletal Radiology. And what they looked at was there are a few problems. The first is that nodular type, the type that I'm saying that can be misconstrued as an intra-articular body just from arthritis, that what people call blooming. And blooming means that you have like a dark spot on the MRI. The dark spot becomes larger on this sequence. That can be a finding that you see in hemorrhage, like with this diagnosis of tenosynovial giant cell tumor, or it can be seen with things that contain metal. We use it in other parts of the body, like the brain, to accentuate, oh, that person has an intracranial hemorrhage. That's actually where its primary utility is. So it's not used most often in musculoskeletal imaging. So you go to any place, that's not going to be their standard protocol to do a GRE sequence. Now, if they have a clue on that diagnosis, they may do it. But the problem is that there's very high inter-observer reliability, very high and the other thing is that with the nodular type, if you look at that study, it was less than 50% of the time they deemed that it was blooming on the nodular type. The diffuse type, most of the time, I believe it was about 87% of the time, that showed the blooming artifact. I'm saying the diffuse type, I think less often could be misconstrued, or less often at least it's not a consideration between other diagnoses of, like I said, of hemophilia or some other reason for recurrent hemorrhage, rheumatoid arthritis. So what would be my protocol? Still stick with the standard, meaning start with a radiograph, do an MRI. Hopefully you are then clued on the diagnosis. If you have a question of it, then to do an MRI with IV contrast. I think it's the most appropriate thing. Do you want to do a GRE sequence? If you feel comfortable in looking at it and interpreting it, certainly. But if it's not part of your standard practice, you may not know how to interpret it, and it may not add value, and you're just adding extra imaging time for the patient that's unnecessary.
Standard MSK imaging, radiographs first, then non-contrast MRI. Fine for 99% of cases, but for TGCT, IV contrast is really helpful. TGCT avidly enhances on post-contrast imaging, while intra-articular bodies from arthritis do not. This distinction can be definitive. Regarding the GRE blooming artifact, it is far more nuanced than textbooks suggest. In one study, nodular TGCT showed blooming less than 50% of the time. It is useful when present, but its absence does not exclude the diagnosis. What should a sports medicine physician do when the radiology report says one thing, but the clinical picture says another?
This is a very tough question because you're asking me as a radiologist of what should a sports medicine doctor, who's not me, do. But I guess, and so that's a tricky one. But for me, I would say that if the imaging, and this is something everybody should consider, that And I like this. Sometimes people will ask me to look at a study again, either for one that I looked at or even one of my colleagues looked at. Like, would you mind looking at this study again? That's actually helpful. Like, if you, as the clinician, look at the interpretation and you happen to look at the images and it just doesn't make total sense to you, it's okay to question. It's okay to ask a second opinion. And then we can look at it again. So again, I'm not the one seeing the patient. They are, but I'd probably say if the interpretation doesn't exactly match what you found on physical exam or the patient's history, then at least reach out to the person again. As far as asking for some other group to do a second opinion, certainly that's another option. It's kind of, I think you have to make that decision based upon what level of comfort do you have with the people that you are dealing with primarily, and what do they deal with primarily? Are they reading everything? Everything, from they could be doing a breast biopsy to then doing an esophagram to then reading a brain MRI, and that takes a certain skill. Or are they very subspecialized, and that they may see certain diagnoses more often? Also, it's funny, there was some research, I don't remember this was from many years ago, about radiology terms and looking at what's the degree of certainty based upon what people say, meaning that suggestive of versus concerning for, like that, even that verbiage. But your question was about when should we escalate it? I would probably say again when there's this question of like non-specific mass, and like going way back to the MRI characteristics. And when I said non-specific and it has, they say either low or intermediate T1 and T2 signal. That would be one thing. The other is, I said there's some overlap of other diagnoses. And when they throw out something like gout, but it doesn't make any sense. So gout, we commonly think of classically, okay, somebody who gorges themselves, somebody who's potentially has some, metabolic disorder or something along those lines. They're typically overweight. But what if it's like a 25-year-old athlete? Seems unlikely that they're going to have a diagnosis of gout. But yet the MRI interpretation says non-specific. And when you look in the findings or something about it's this intermediate to low signal mass. That would probably be my big one. It's just if we say non-specific and we say non-specific intra-articular, because the tenosynovial giant cell tumor of the hands, like I said, I'm kind of keeping that separate. I'm kind of assuming many people are keeping that on their radar. But shoulder, knee, some other joints, I think people tend to forget about.
If the interpretation does not match the clinical picture, call the radiologist. Ask them to re-examine. A second opinion is always an option. Specific red flags and reports like nonspecific synovitis in a young patient with no arthritis on X-ray, a suggestion of gout in a 25-year-old athlete. These mismatches should trigger escalation, not acceptance. For sports medicine clinicians, ordering imaging, what brief history, what note makes the biggest difference to what you look for?
So, what could they do for the diagnosis? I think that the main thing, I said that I said it earlier, while we as radiologists commonly can figure out the history based on the imaging, you had brought up hedging. Sometimes it's an either or situation and we need the history, and the history you provided could sway us in one way or the other. So could be a history thing.
Right.
Of something of like, recurrent knee swelling. But X-rays show no arthritis.
Right.
Something like that. So I'm not asking for a paragraph history, but just something that just things don't jive.
He is not asking for a paragraph, something like recurrent knee swelling, x-rays show no arthritis. That is infinitely more useful than quote unquote knee pain. It changes the search pattern, it raises the index of suspicion, and it takes 10 seconds to write. So if radiologists took away one change from this conversation, what would it be?
I touched on it repeatedly. If you see a mass that's relatively low on T1 and low on T2 signal, MRI characteristics, and then think of at least this diagnosis. Think of tenosynovial giant cell tumor. That's in the nodular type.
If you see a mass that is related to a joint and it has certain MRI characteristics, low signal on T1 and T2, joint associated, think of this. Think of this diagnosis, TGCT, CATCH-TGCT. Dr. Botany has shown that the gap between recognition and diagnosis often lives in the space between what the clinician writes and what the radiologist reads. But once TGCT is suspected or confirmed, the pathway does not end, it evolves. To close the series, Dr. Carr Asher returns to address the questions sports medicine physicians have about what comes next. What are the main treatment modalities for TGCT today, and how should sports medicine physicians understand where each fits?
Yeah, so there are several treatments, which of course surgery is always an option. In TGCT, it's either the localized or the diffuse type. When it is localized, surgery is always a reasonable option to discuss. I think for the diffuse type, it tends to be a little less helpful because you can clear out as much of the disease as possible, but it's really hard to get everything. And so I think in the case of diffuse TGCT, that surgery probably has less of a role. But I also think early referral to orthopedic oncology to have those discussions and make those considerations for surgery are really important because of their expertise. But in terms of systemic therapies, there are a couple of options out there now that all target CSF1, and we'll likely see more systemic therapies coming down the pipeline. There are others in clinical trials, which is exciting, and they're highly effective. So I think having a discussion of systemic therapy is really important, and balancing that against surgery as an option, because these medical therapies, while they do have side effects, right? Everything has a side effect, certainly. There are also side effects to doing these surgeries, right? And there's morbidity that comes with these surgeries, especially when people have had multiple surgeries in relatively short periods of time, especially people who have decades in front of them. So I think it's important to balance both. And I think there are side effects to the systemic therapies, but those can be balanced as well, right? And they're at least good to have a conversation about both options. And I think that's why these conversations are very nuanced, right? Because some people hear about the side effects of the medical therapies or the systemic therapies and say, no, that's not something I want to do, right? Or they hear about the surgery and say, no, that's not something I want to do. So presenting them with multiple options is important, and help letting the patient sort of determine their course and navigate their treatment, I think, is really important. In terms of systemic therapy options, I mentioned there's a couple of choices out there. I evaluate a lot of patients for TGCT. I don't treat them all. I think it's important to keep in mind that not every patient needs to be treated right away. Right? For me, the first questions I always ask are, how is this impacting your day-to-day? Right? Are you able to work? Are you able to care for your family? Are you able to run your errands? Right? And getting a sense of how the disease is impacting their day-to-day, and finding out what are the things they want to do that they can't do, right, because of their TGCT. And that will often guide the discussion to get an understanding of how much it's impacting their life. And it's really once it's having a significant impact on their life, especially if you have young people who can't work, right, can't care for their children, these sort of things that really pushes you to have these discussions about systemic therapy. But if there are people who it may not be impacting their day-to-day significantly, right? Maybe it's, oh, I used to run marathons and now I can only run a mile or two, right? While that's an important quality of life issue, right, they may not need treatment urgently, right? So it's really about, finding out how much it's impacting them and then determining whether or not they need to start a therapy or at least consider a therapy.
Surgery is always an option for localized TGCT. For diffuse disease, surgery has a more limited role. It is difficult to clear everything, and recurrence is common. Systemic therapies targeting CSF1 are available and highly effective and expanding, but not every patient needs treatment immediately. Her first question is always, how is this impacting their day-to-day? Are they functional? And if the impact is limited, watchful observation may be appropriate. Treatment is individualized, not reflexive. What do you wish sports medicine physicians understood about the full downstream care pathway once TGCT is on the table?
Yeah, I think what I'd like to emphasize is the importance of having these multidisciplinary discussions, because I think it's sometimes easy to stay in our silos, and I do that too, right? I see a patient with TGCT, I offer systemic therapy, right? Because I'm a medical oncologist, I offer systemic therapy, but I think it's important to have a discussion and hear about, well, what do the surgeons think, right? What are the other potential local treatment options? Does this patient even need treatment? Could they have some conservative management, right? Would physical therapy or something else be helpful to them, at least in the short term? So I think having these really nuanced discussions with everybody in the room is really important. And so I think getting a patient to a place where they can have those discussions with multiple providers who are all looking at the imaging together, right, have all evaluated the patient, and then we can sort of debate and discuss, and then sort of present the best options or the consensus of the group to the patient and help try to guide their treatment that way.
The importance of multidisciplinary discussion. It is easy to stay in silos, and she offers systemic therapy because she's a medical oncologist, but the right answer requires hearing from surgeons, asking about conservative management, and sometimes deciding that no treatment is needed right away. Having everyone in the room, or at least in the conversation, is what produces the best outcome. What are the most preventable sources of delay that we could realistically address through better education in sports medicine?
Yeah, I think an imaging delay is one of the things that I'll see a lot, where because it's tied to this injury, right, and maybe they have physical exam findings that are consistent with a certain sports injury, then imaging won't be obtained at the beginning, which can be understandable. But again, is if they're not improving and they're not sort of progressing in the way you'd expect, I think having a low threshold to get the imaging done, to kind of broaden your differential is important.
Imaging delay, because the symptoms get tied to an injury, because physical exam findings are consistent with a sports diagnosis. Imaging is not obtained early enough. A low threshold for imaging when the expected course is not materializing, that is the single most addressable gap. If sports medicine physicians took away only one message from oncology about TGCT, what would you want that message to be?
Yeah, I think that this is really a nuanced and complex condition, and that multidisciplinary care is so important, and creating partnerships with orthopedic oncology and medical oncology is so important to ensure that these patients have the most optimal quality of life with this really long-term condition.
This is a nuanced and complex condition. Multidisciplinary care is essential. Creating partnerships with orthopedic oncology and medical oncology ensures patients have optimal quality of life with a condition that is genuinely long-term. Diffuse synovial thickening, hemosiderin disposition, avid enhancement with contrast, the imaging findings are identifiable, but interpretation evolves with context. Nonspecific synovitis at 6 weeks reassures. At 9 months, it reframes. Sports medicine sees the trajectory. Radiology sees the structure. Oncology sees the biology. When these perspectives align, and they align earlier, the diagnostic path shortens. Recognition, as described across this series, rarely arrives loudly. It becomes visible when duration outweighs mechanism. Most joint complaints follow a predictable arc. TGCT does not disrupt that arc immediately. It alters it gradually. Recurrent effusion, persistent non-articular synovitis, stable but unresolved imaging language, a plateau in recovery, and at some point, the defining feature becomes time. When duration outweighs mechanism, the diagnostic lens shifts. Recognition appears to emerge when continuity, context, and imaging all align. And that alignment, when it occurs earlier, changes trajectory.